It's my pleasure to introduce Dr. Don Jenkins. I think most of you know Dr. Jenkins well, but maybe a few things you don't know about him. Don did undergraduate at the University of Scranton in Pennsylvania, and then from there went to the Uniformed Services University for the Health Sciences, where he completed medical school. Following medical school, Don, we were the beneficiary that Don wound up in San Antonio at Wilford Hall with the 59th Medical Wing. Once he graduated from residency, he went to the University of Pennsylvania to complete his training with a surgery, critical care, and trauma fellowship with Bill Schwab. That's been a tremendously successful program, and Dr. Jenkins has been one of its most successful graduates. Following training, Dr. Jenkins again made his way back to San Antonio, where he became the trauma medical director at Wilford Hall, where this is really where I interacted most with Don in those days, and Don, along with a number of others, was a key leader in developing our regional trauma system. One skill that Dr. Jenkins has is a master team builder and getting people to work together. From there, he moved on to the Mayo Clinic, where he headed where he was the division chief for their trauma program and totally organized the entire state of Minnesota. I was talking to him on the phone just a few minutes ago. I said, this is sort of like Minnesota this morning, and he said yes, but warmer. So we were fortunate to be able to. Don has some grandchildren. We were fortunate to be able to recruit Dr. Jenkins back here. A couple of notable things that I didn't mention. If you look at the organization of the trauma system in Iraq and Afghanistan, that was definitely a team effort, but we're very fortunate to have Dr. Jenkins and Brian Eastridge, both of whom were key architects of that entire system. And lastly, Don's won many awards. He received the American Legion's highest award, its Distinguished Service Award from the American Legion. It's my pleasure to introduce Dr. Don Jenkins.
Well, thank you for that generous introduction, Dr. Stewart. Appreciate that. Today we're going to talk a little bit about trauma, injury, wounding, and something about wound infection and/or wound infection control. Given my role in quality here, thought that this would be a good topic to discuss. So we're going to talk about some military experience. We're going to talk about some of the science behind it. We're going to talk about some other things that we did now using that bit of science and the background that we laid. And then finally, I think some of the things that eventually came out of those initial efforts and put them into a manuscript form. I have nothing to disclose about today's lecture. But do have many to acknowledge for all of their hard work in making the changes that needed to be made to help improve care for our injured combatants. So combat today is a little different than it was in previous conflicts in terms of body armor and the type of wounding that we see, because far fewer torso injuries than there had been in previous conflicts, perhaps fewer head injuries than seen in previous conflicts as a percentage based upon body armor and the armored vehicles, etc. But the end result really hasn't changed terribly much. War is a dirty, grimy business, and these are the worst consistently bad wounds that I've dealt with for any prolonged period of time. And I'm going to show you some examples of that military style of wounding. Now, this is the difference that being dead, being shot point blank 7 times in the chest with an AK-47 makes when you're wearing the proper protective gear. You get a blunt force injury behind that body armor, but you don't get dead because of all those penetrations. So a little different wounding there, and that can actually go on to full thickness necrosis. Something we just hadn't really seen before or were necessarily prepared to deal with, but those wounds do observe or do deserve close observation. Higher power explosive devices, regardless of what they be, leave behind very devastating wounds. And you can see how this happens in a field environment and a guy who's already dirty, and then it's hours until they can get to definitive care. This is a prime setup for wound infection and wound sepsis. You know, it's one thing to save this guy's life on the day of the injury and keep him from dying of hemorrhage. It's a whole other thing to have him die 2 weeks later of sepsis back in Walter Reed or at the ISR. So you got to do things right on day one in order to preserve that soldier's life. This is an example of a gunshot wound that came in through the side hole of the armor and fortunately stayed extrathoracic. But again, you can see that's just a single projectile that's caused that wound devastation. And that's going to take some time to heal, and a lot of bad things can happen on the in-between. This is the environment in which we provided that care. So dusty old tents, right, Rich? Yeah, you know this well. Dusty old canvas tents with cotton liners, environmental control units trying to keep the temperature down inside of that tent hospital on a continuous basis, sucking in dust from the outside. Little tiny foot pump sink over here to try to wash your hands and get as clean as you can. This is how it was when we took over, and you can see that the plastic here that was intended to protect this operating room, it was never down. It was brand new from the day they put it up. When we took over that hospital, and we had to do some things a little differently to get the place cleaned up. We'll talk about that. This is an RPG fired through the door of a Humvee, through the boot and ankle of this particular soldier. It was too close, didn't make enough revolutions to be armed, so it didn't detonate, but it went through his ankle. And you can see, again, if you haven't dealt with these kind of wounds before, it's deceptive, the degree of tissue injury that exists, because to get this fellow to the operating room, and there are fragments that go almost all the way up to his knee joint. From this kind of a wound. So a devastating wound that if you just try to do something minimal to this guy's surely going to lose that leg, if not his life. And it was some crowded conditions. This was a 10-day period of time. We did 450 operations in 3 operating rooms, major trauma operations during this 10-day block in November. And it was a pretty busy time. You can see Mike Eppinger over here operating with Joe Brennan. And I'm operating on the abdomen with a urologist because we spread out the 6 surgeons. Steve Abbott was there with us, you know him, Darren Danielson, Greg Abrahamian, and Zarnik. He was from somewhere else. We had 6 general surgeons. We spread them out across those rooms, 3 orthopedists, 1 per box. And we did 70 operations in those 3 operating rooms the first day of that operation. And we didn't lose anybody. No U.S. soldier lost his life in our care during that 10-day block of time. You look back now at the historic reference, and this is, these are things that we were taught at Uniformed Services University. There'll be a grand round speaker coming to talk, and probably will mention some of this same work in February. But if you had colon trauma in World War I, just like an Old West cowboy movie, you got shot in the gut, you were going to die. It was going to be a slow and painful death. In World War II, the mortality was so high following abdominal trauma that the Surgeon General mandated everyone with a colon injury get a colostomy. And that stuck for 40 or 50 years almost. And it wasn't until more modern times when, with the use of antibiotics, that you could do some primary repairs and not have to do a colostomy. But there was still quite a bit of infection seen in these patients. Cut break and go to some science coming out of the combat zone from early in the war in Afghanistan. Very high infection infection rate in these patients with abdominal injury, 5.1% rate of injury to the colon in that group of patients with abdominal injury, and nearly 1 in 6 with sepsis in that patient population. More than double the mortality if the colon is injured than if it's not. Now, there are contributing factors to this that lead to infection in this patient population, and there are things that are beyond your control. If the patient needs a transfusion, they need a transfusion. If there are more organs injured, and the average is like 2.5 per gunshot or per fragment, then that's going to raise that injury score and increase the risk of infection of development. And if the stomach or the pancreas or the colon is injured, that rate about doubles. Also, if there's delay to definitive care, another one of those things that you don't control, then that increases the risk of infection in these patients as well. So multiple sources from the 1970s, and they're all listed down here, demonstrated that you can mitigate infection if you give antibiotics preoperatively and make sure that you have good aerobic and anaerobic coverage. What was further discovered was that 24 hours of antibiotic coverage in the perioperative period is equivalent to 5 days worth of perioperative coverage in these patient populations. And the risk here is multiple drug-resistant organism development, which we surely saw in the combat zone, coming back to places like Walter Reed, where they were able to identify down at the DNA level that the transplant patients at Walter Reed were getting the same exact Acinetobacter infections that the soldiers had. And it's all just straight up good old-fashioned infection control about who's washing their hands and who's not washing their hands, and how you prevent that from going from one person to another. Where in the soldiers, it was mainly a commensal organism or a nuisance. It was deadly for those transplant patients. So as we talked about these findings, one other thing is that little over 10% of these patients will go on to develop chronic abscesses. And so the gift that keeps on giving here, that the odds ratio for development, as I said earlier, was more than double if the colon is injured as a part of that abdominal trauma. Now, there are wound problems that happen, and we demonstrated, I think, some of those in our practical experience that we showed earlier in the talk, is that there can be a delay in surgery. You can have wounds that are inadequately debrided. We routinely received wounds on civilian patients that had been seen and addressed and washed and closed at a referring center, only to take the patient to the operating room and find grass and mud and leaves and non-debrided devitalized tissue that really should have been debrided at the first debridement. You also shouldn't close wounds, primarily in war wounds, and that's pretty clearly written out. And we did change the book on that a little bit, and we'll talk about that a little bit later in the talk. If you develop hematoma due to inadequate hemostasis, it's a great place for microorganisms to want to grow. If you leave retained foreign body, like we talked about, if you don't provide adequate drainage, and you should never close war wounds primarily. Missing injuries is a big deal, and we learned pretty early on that every fragment hole really needed an extension of that incision and incision and drainage. And it was really surprising to us that you would have a 1 centimeter skin wound and a 3 centimeter piece of rock in that patient. You can't see that on CT, you can't see it on X-ray, and certainly that would have caused that injured combatant an infection. I don't know how many of you have experience with these kinds of wounds. It is not the same as operating on a mangled extremity from a motorcycle crash. Would you agree with that, Carlos? It's a little different, yeah. And it does take what we call on-the-job training, a little right seat, left seat ride with somebody who's experienced this. It was surprising to us as things got better in terms of evacuating casualties to us. We saw a change in how things happen, is that you would start the debridement, let's say on the right upper arm, skip down to wounds in the flank, go down to the right lower extremity while your partner was doing the same on the other side, and go back up to the top to start putting dressings on, and there was more dead muscle where that just had been bleeding and contracting. And so these were wounds in evolution because of the explosive nature and so operating on these patients very rapidly almost was a problem. It was a lesson we learned from the combat support hospital in another city who evacuated their patients to us, and went in and asked them how things were going, because we were opening up a lot of their wounds and debriding more dead muscle. And they said it was interesting to them that the Americans seemed to do so well, but the Iraqi patients all had to go back for additional debridements. And I'm like, well, there's nothing miraculous about an American soldier that is different tissue healing. That's what's happening. They are opening up your wounds and debriding them because they're inadequate. Use your local patients as the canary in the coal mine to know how things are really going. So that's part of that right seat, left seat ride. And if one doesn't know what the other is doing, or they don't get feedback, which they weren't getting feedback, then they can't change how they do things. The particulars also would be, you wouldn't expect the patient to be operated on, in Hondo, and then at Baptist, and then moved over here to University for their third operation in 3 days. That would not be the way of providing care, but that's the scheduled care that we delivered in the combat zone. So there's a lot of interruption of that continuity of care. And then there's some funny things that can happen to patients, a whole different lecture during high altitude air medical transport, and limitations in the back of a plane in terms of what you can do for a casualty. So now we'll talk a little bit about the science of wound healing. And these are the stages of wound healing. It begins with hemostasis, then moves into an inflammatory phase, a proliferative phase, and a maturation phase. And Dr. Dent specifically asked me to include some of this because it's heavily weighted on the ABSITE in terms of different aspects of wound healing and what their role is in healing. So we'll take them one phase at a time. This is sort of along a timeline from minutes to hours to days to weeks to months in terms of where those phases fall. And the lecture will be available to you on the website for general surgery. So if you want to go back and look at this, you're welcome to do so. But this is how those phases fall over time. Thank you very much, Wikipedia, for this nice graphic. You can go right there and pick it up yourself. So hemostasis begins with platelet adherence, activation of fibrin, then clot formation, and clot strengthening. This is where, if you don't get this part right, the hematoma forms and you end up with an increased risk of infection in your wound. The inflammatory process follows on now with phagocytosis of dead tissue as well as microbes and the ingrowth of microbes into that wound. And platelet-derived growth factor is released, and this stimulates then the next phase, the proliferative phase, to happen. In the proliferative phase, angiogenesis comes first. Then collagen is deposited, granulation tissue begins to develop, fibroblasts now move into the wound to excrete more collagen and fibronectin and develop a new extracellular matrix. Eventually, myofibroblasts take over and start to contract that wound. And we're all familiar with these stages just by watching our patients serially in the inpatient setting or even in the outpatient setting about how this happens. In a maturation phase occurring out months to years afterwards, collagen is realigned along tension lines and non-essential cells are gotten rid of out of that wound until maybe 25 years later the scar fades to nothing. You can't even see it hardly anymore. Impediments to wound healing come with some specific issues. So we all know diabetes and infection and cancer and chemotherapy and other immunosuppressants, but the role that those processes have in wound healing is where the test questions come from, right? So diabetes causes a local tissue hypoxia, and there is quite a bit more of tissue destruction in these wounds than in a non-diabetic. The T cell function, leukocyte chemotaxis, and phagocytosis are all impaired in patients with diabetes, and their fibroblasts and epidermal cells are dysfunctional. So it just prolongs that wound healing phase remarkably. Infection due to excess inflammation and the release of endotoxins will slow down or impair wound healing, as well as the release of inflammatory cytokines like interleukin-1. The older a patient is, they heal, the quality of their healing is good. It just takes a little bit longer to happen because there's a bit of inflammatory impairment and a decrease in collagen synthesis, angiogenesis, and epithelialization. Immunosuppression causes fibroblasts to be suppressed, which in turn decreases collagen synthesis and slows down that wound healing. Smoking, tissue ischemia due to nicotine-induced function, and carbon monoxide decrease in the fractionated oxygen content of the blood leads to tissue hypoxia as well. Now, nutrition, there are so many factors that go into nutrition. We broke this up into subsequent several slides. So we'll start out with vitamin A, which is responsible for fibroblast proliferation, collagen synthesis, hyaluronate synthesis, and decreased extracellular matrix degradation. Vitamin C has an important role in collagen synthesis and angiogenesis. Vitamin E protects from oxidative destruction. Magnesium is a very important enzymatic cofactor in the production of protein and collagen. Zinc is an important cofactor in RNA and DNA polymerase so that you can grow that new extracellular matrix. And iron results in hydroxylation of proline and lysine, giving you functional proteins to put down in that wound to form that collagen in the beginning. Copper is an important cofactor for cytochrome oxidase and superoxide dismutase, and is involved in collagen cross-linking. Arginine is a proline precursor, and it interferes with collagen deposition and angiogenesis if there is a deficit. Glutamine provides the metabolic energy for fibroblasts, macrophages, and epithelial cells. So if your overall nutrition is poor, that's going to lead to wound healing impairment as well. And then there are several growth factors that play an important role in wound healing. Epidermal growth factor comes from macrophages and is responsible primarily for the development of granulation tissue. Transforming growth factor alpha comes from macrophages and is involved in epithelial cell proliferation. Vascular endothelial growth factor comes from mesenchymal cells and obviously is responsible for endothelial cell proliferation. Platelet-derived growth factor obviously comes from platelets and is largely responsible for chemotaxis of granulocytes and macrophages, as well as production of fibronectin and hyaluronate. Fibroblast growth factor 1 and 2 come from mast cells, are involved in chemotaxis and proliferation of fibroblasts, and angiogenesis and collagen deposition. And then transforming growth factor comes from lymphocytes and endothelial cells and is an inhibitor, again, of tissue breakdown in those wounds. So having been through this indoctrination period, being introduced to these wounds and a healthcare system that wasn't fully functional and a disjointed care and not getting feedback on the work that we were doing. We could do the same thing every day, believing we're doing the right thing. If we don't get feedback to find out that there were problems, then you just make the same error again and again and again. One of the things we saw when there was a change in personnel at one of the big combat hospitals, that all of a sudden the guys in Germany were seeing a lot of ventilator-associated pneumonia that they hadn't been seeing. And I took a little trip to that hospital and watched in horror as the respiratory therapist, with no gloves and no hand washing in between patients, disconnected the patient from the ventilator and did open suction on that, and then moved to the next patient and do the same. And I the chief nurse of the ICU in and the chief physician, and I said, "What this? Do you not see what's happening here?" And he said, "Oh, it's okay. The soldiers aren't here long enough to get ventilator-associated pneumonia." I'm like, what kind of magical thing? Yeah, that's right. They're in Germany getting their pneumonia. That you start, what the? And so we had to go back to Infection Control 101 in the whole combat theater. So these are the principles that we laid out that became the core of our operation. And so every wound got reopened. We did very aggressive debridements. We would never use artificial conduit in these patients unless there was absolutely no other choice. We started to get into wound vacuum devices, and we'll get to that here in just a minute. But these were the general principles up front. We were very careful with the antibiotic choices and made sure that we had proper tetanus prophylaxis in our patient population. Yep, sorry, I already talked about that. So we were using negative pressure wound therapy devices on local patients that the Army had procured at our site. And we were using these to help stimulate granulation in these patients' wounds to get them to skin graft. And it seemed to work fairly well. And it seemed that the patients that had wound vacs versus those that were doing dressing changes on had less pain and shorter length of stay. And so that caused us to want to look into that a little bit more. Now, the problem was we couldn't put the device on U.S. combatants and then put them on an airplane because the device wasn't approved for use in flight. Now, you'd think that that would be an easy thing, an easy fix, right? I mean, what can't you start up on an airplane? It set off the chafe and flares in the C-17 when you turn on the wound vac machine, which is not, you don't want that. That's not a good feeling. It's not a good noise, and you're taking away half your protection now as you're trying to take off. So so they had to literally go and re-engineer the device so that it didn't trip that. It took about 3 years to get that all ironed out, but we eventually were able to do it, and it was a game changer for us. And it was Mark Richardson. I don't know if any of you know Mark Richardson, orthopedic surgeon. We were classmates together, and then ended up at Wilford Hall together. It was Mark who came to us and said, you know, these extremity wounds are looking really good at that second operation. I think we should put wound vacs on these guys. And so we started to do that and saw that in short order we could close these wounds primarily. And we'll show you how that worked out. Now, negative pressure wound therapy increases wound blood flow, increases and speeds up granulation tissue formation, decreases bacterial counts, and stimulates wound healing pathways. It's also possible that it takes away some of those cytokines and endotoxins from the wound that impair healing as well. But this is the rough science behind that. This is an infected thoracotomy wound that we saw. Cleaned this up per our regimen. At the time of the second debridement, we placed the negative pressure wound therapy device, get them back to the operating room 2 days later, and it's remarkably cleaned. And we were able to now close this primarily over a drain, and that not only does the guy live to tell the story, but doesn't get an infection any further. That's what that looked like after it was closed up. And this guy was shot through the anterior superior iliac spine and a second gunshot across his buttock. In fact, it just skips past his anus and goes into his other buttock cheek. This is a very extensive wound. It's kind of hard to appreciate here how much tissue destruction there is until you get in there and start to open up that wound for exploration. And you can see the extent of those wounds and the location, and there's the other wound in the other buttock cheek right there at the level of the anus. I think you'd look at this and you'd have to say to yourself, you can't close that, right? I mean, so we redebrided, and most of it we were able to put wound vac on and then close primarily, as you see here, except for a little spot where that tissue was just missing from the beginning. We put a skin graft on there. Gets wound vac treatment, and then he's a local patient, so comes back to see us, and this is what he looks like on day 30. That entire wound is completely healed. There's no evidence of infection whatsoever in those wounds. And so Brian Leininger helped us put this together in a little study. We studied 75 patients, most of them with IED injuries to the extremities. Their historic length of stay for those patients was 30 days. We chopped that down to less than 8. It eventually got this down to a science of 2 operations per patient with 4 days to wound closure, and with 100% follow-up at 30 days with these patients, no wound complications and no wound infections. So this is a game changer in terms of management of combat wounds, and caused a big influx in the number of wound vac devices that the military bought and put in airplanes and in the continental United States facilities. So the other things we did was, just like good infection control, was we said, okay, if you're going to touch a patient, you have to wear gloves. The people we took over from were wearing their boots and their outdoor attire into the operating room instead of wearing scrubs. I had conversations with Department of Defense Global Emerging Infection System, DoD GEIS, as we realized that there was this Acinetobacter problem and what could we do about that. And they suggested that they had just done a couple of studies and that the typical isopropyl alcohol does not affect it whatsoever, that it grows, in fact, it proliferates, that if shiny metal surfaces can be cleansed with a chlorhexidine type of substance, that's really good, or UV light. And you could also boil it, and that would help. And so I said, well, fellas, listen, while I'm on this treasure hunt looking for a cauldron and a canoe paddle to boil my patients and my machines, how about something more practical? Could you give us a commercial substance or, wipes or something that's going to kill Acinetobacter? And what about if we heated up the water to a higher temperature and then added detergent? Would that make a difference? So I don't have to boil things. And they're like, that's a great idea. I'm like, yeah, here on Earth, that's how we think about things like this, just practical nature of things. So we did those studies, and of course, you've got these wipes, they're everywhere, that become ubiquitous now to take care of those kind of problems. But again, that was a case of the right hand not knowing what the left hand was dealing with these infections. We did put up that plastic draping. We cleaned everything off. We cleaned everything out. Eventually, we convinced the Air Force to use stuff in the inventory that was sitting in storage in Iraq, these chemically protected liners for the tents. They're a very durable plastic, very easy to clean, instead of that cotton liner. So you can actually wash them down, because that cotton liner, there's nothing you can do with it. It gets dirty, and you have to throw it away and put up another one. It doesn't really provide much in the way of protection. It certainly doesn't protect from dust. And every time a helicopter would fly over the hospital, the dust would fall from the rafters, just like a scene from a movie, like right onto the patients. And it was a mess. So we got them to do that. Got them to put HEPA filters on those air conditioning units, so that the air was truly OR quality air, and the infection problems seemed to melt away once we adopted those things. They also weren't cleaning the air ducts. They weren't cleaning the filters on these things, because that was a scheduled maintenance item every 90 days. So that might be true for the chow hall, but that's not true for my operating room. And we're going to do this every week. We also had the had just enough room to open up a third operating room so that we could decompress those 2 operating rooms we were using initially, and we opened up a third ward so that we could decompress those patients. We stopped doing any kind of dressing changes at all in the ward. Everything went to the operating room where it was clean, and we used one of those operating rooms almost exclusively for dirtier cases and kept the brains and eyeballs out of that room altogether. We regimented that wound care and antibiotic usage. We cleaned up the ICU and the emergency department and the ward just in the same exact fashion that we had done in the operating room. Yep, there's our longer soak, and we added bleach and hotter water to clean the linens. It's interesting, you know, that every soldier that came through and was evacuated out of country had that old World War II issue olive drab green woolen blanket. And I don't know if you've ever tried to wash a woolen blanket, but it turns into a washcloth at the end of the wash and dry cycle. So it's a one-time, one-patient use only kind of an item. They also hadn't been cleaning off the litters, and we'd get a casualty in, you'd be waiting for a casualty to come in, and you look at the litter, and there's blood and guts on it. It's like, what the? Well, we didn't have enough litters for this big influx of casualties that we were seeing at that time frame. So we had to add extra personnel, a litter washing station, and get about 20 more litters so that we could keep them clean and try to limit infection in those patients. But unless you had that hat on, that mindset, if you're not thinking about those things, then you're going to miss those and potentially end up with some infection problems. So all of that work was carried out and extended across the theater, as Dr. Stewart mentioned earlier, in terms of trauma system development. We did our best to put infection control experts out in the field to take a tour around and to see what was being faced by the clinicians on the ground in those austere environments. Came together, put this work together in a supplement for the Journal of Trauma, published in 2008. We rated the strength of those recommendations and the quality of the evidence, the lowest level of evidence, expert opinion, number Roman numeral 3, as you see. And A and E, pretty strong evidence to or not to do a thing as you go through that recommendation rating system. So regularly updated antibiograms, enforcing infection control techniques, early field use of antibiotics, no need for intraoperative cultures, make every attempt to get that casualty operated on in less than 6 hours from the time of injury, and then good old expert opinion on irrigating the abdomen at the time of the initial operation. And the amount of irrigation to be used. Early primary repair was discouraged, and we saw a 13% colon leak rate in casualties who are going under primary colon anastomosis. So we asked that they not do that, let the guys in Germany put that together after a period of stabilization for those patients. Presumptive pre-op antibiotics with the strongest evidence and recommendation for up to 24 hours. And do not use the carbapenems because that was helping to lead to the multi-drug resistant Acinetobacter problems we were facing back here in the continental United States. Wrote the post-splenectomy immunization guideline. It was a horrifying thing. I went to do some consulting in Germany at Landstuhl Hospital as they were getting ready for the American College of Surgeons to come in and do their level 2 site visit. And I uncovered 27 out of 50 soldiers with splenectomy left Landstuhl and had no evidence of ever having received post-splenectomy immunizations. So over half of the patients that got splenectomies, there was no evidence you could find that they had received immunizations. We were able to track them all down and make sure that they got those immunizations eventually. But there was something broken in the system at that point that we had to fix, and wrote a practice guideline all about that. Those recommendations were implemented by the help of a lot of really smart people, very diligent in their work. We reviewed all of this with all the in-theater surgeons. and we were able to begin to track this data in the trauma registry for future use. We felt it was important to send infection control expert into the combat zone at least once a year to take a tour around of the combat support hospitals to make sure that there were no new things happening that needed to be addressed, and that we took this to all the services to update their training and teaching before sending their clinicians to the combat zone. As of 2007, the way ahead was to get a coordinated effort through the trauma registry, look at that data, and then devise a list of questions to be answered as we put together prospectively in this database of the things we wanted to know about these casualties. A little bit of that work was done in this study published in 2011, where they looked at 356 casualties, about a third of whom developed an infection. Of those, there were 117 unique events that were identified of infection in those 104 casualties, with follow-up out to 6 months. The majority of these were soft tissue infections, but almost 20% of these injured combatants had a bloodstream infection at some point as well, which can be deadly. Same with the pneumonia. 1 out of 6 of those infections was a pneumonia. As we talked about, there was a particular problem in Germany with the development of pneumonia and why that happened, and that wound infections, more than 17% of the wound infections were diagnosed only after getting back to the continental United States, meaning it took 4, 5, 6 days for the wound infection to show up. So it wasn't happening early, and perhaps there's something about the early surgical technique or the duration of antibiotics that was insufficient for these casualties. Now, this was just about the time that this work was, the study population work was completed when wound vacs had been introduced within the previous few months. They really had been in the system only for about 8 or 9 months at this point in time. And as you might imagine, there was a comedy of errors because nobody thought to train the nurses in the back of the airplane how to work the devices, and so they would make this beeping noise and they would shut them off so they would stop beeping and just leave the wound dressed up in plastic and let it ferment for the 12 hours from Germany to Walter Reed, and that led to some additional problems as well. Interestingly, that nearly 1 in 4 of these infections first occurred back home. And so surveillance isn't over just because the casualty gets back home to the continental United States. There's still quite a bit of infection that can be seen in this patient population. Well, that brings us to our own data here, and thanks for Christy being here with us this morning, providing this information. As you can see, over time, our superficial surgical site infection in colon-operated patients here. This comes out of the NSQIP data set. The trend line where we want to be below is here. We were above that line for several quarters here, below that line, and we've been doing pretty close to what's expected. So we keep a close eye on this. This is risk-adjusted data, so better than raw data. In terms of where we stand. At the end of the day, it's not good. We need to be well below that trend line. You'd like to see those error bars fall below that trend line, and then you'd be a good outlier in a very good way. So we are introducing some things to try to help with that. A colon bundle path and rapid recovery pathway that we're working on implementing, and then taking some core elements out of that for most of our patients to see if we can help lower some of this infection. These are all cases of surgical site infection. You can see that once you get away from the colons where they've been doing colon bundle and you start adding in other cases to this, that infection rate jumps up. And it's a bit alarming. We're in one of the lowest deciles for this in this risk-adjusted NSQIP benchmarking program. So we're going to be counting on the senior and chief residents as we implement these ERAS pathways to be sure that our patients are being put on those pathways and we're following those pathways and all the elements of those bundles. And Christy and I will be back here periodically to update you on this information and on the elements of those pathways and bundles. And then the NSQIP calculator. We've talked about this before. My strong recommendation is that every case that's presented here at M&M that relates to an infection, we should see the NSQIP calculator values brought to us to increase our familiarity. You can bring it up right on your iPhone. These are the elements that go into that, and many of these are part of the risk adjustment that is used in NSQIP. It is interesting to me that many of the things you might think of, like steroid use and diabetes, are on this list, but albumin levels aren't on this list. As a for instance, not something that's factored in these wound infection and other. So NSQIP calculator gives you more than the chance of wound infection. It gives you a chance of risk of mortality, risk of needing to go to a secondary health care center after the primary surgical care has been rendered, et cetera. So there's quite a bit of information that's in there. They continue to work on it and look at the modeling, and they've just changed things this past spring, I think. They changed how their risk-adjusted benchmarking is done, and I think added a new field or two. But these are the things that go into the risk calculator for NSQIP. So my bottom line to you guys is be vigilant, be skeptical. Don't put your head in the sand. If it comes down to, and you think a patient might have an infection, far better to take that patient in the operating room, open up that wound, than to let it fester and get out of control. We certainly have seen cases like that in every institution I've been in. And also, it's up to you, right? As an individual, you have to have your own personal recognizance. And if you're going to be touching a patient and you didn't wash your hands, then someone on your team should step up and say, hey, you can't do that. And you got to wash your hands when you leave, right? Or gel or foam or whatever the case may be. These are your patients, and you have to set the example. So involve the entire team with that and follow through and enforce those.